Welcome to ATCM, the emergency medicine channel. Yes. Presenting the case of a 28-year-old female who came to ER with complaints of multiple episodes of vomiting and loose stools since last 2 days, and she complains of reduced fetal movements since today. So on initial 10-second assessment, the patient was conscious oriented. She was talking in full complete sentences. On assessment of airway, it was patent. There was no pooling of secretions tried. And on breathing, the saturation was 96% in room air with a respiratory rate of 18 per minute. Urinary was bilaterally equal with no added sounds. And circulation wise, the heart rate was 80 per minute with a BP of 106/60 millimeters of mercury with a capillary refill time less than 3 seconds. And disability wise, GCS was E4, V5, M6 with the pupils equal and reactive to light of size 2 mm. And exposure wise, the patient had a GRBS of 86 milligram per deciliter, and there was presence of maculopapular rashes all over the body. And we assessed the pain score. The patient had a pain score of 2 out of 10. So following which, we had also taken adjuncts to the primary survey. We have taken a CBC-CRP, point of care was taken.
What is rubella?
Rubella syndrome is mainly classified by maculopapular rashes with fever. So,
pregnancy and rubella, what is the relation?
It can lead to congenital sensory loss and hearing loss. Congenital rubella syndrome.
Pregnancy, when a patient come with rashes, you have to always rule out rubella.
Yes.
Okay, because we have to communicate with the patient.
Yes. So, following which, we had also taken adjuncts to the primary survey when the CBCR point of care was taken. Total counts of 17,000 with HB of 8.2. The patient had a platelet of 1,90,000 and a CRP of 54.1. Okay. And we had also taken a blood gas which was
what is the hematocrit value in this patient?
This patient had a hematocrit of 24. Yes.
So somebody might have given fluids.
Yes, we had given.
Already given?
Yeah, already given fluids from outside hospital. So we had again moved on to take the sample history. The patient was a 28-year-old female. She was a known case of antiphospholipid antibody syndrome. She was also a known case of hypothyroidism, SLE. Came to ER with complaints of multiple episodes of vomiting and loose stools since the last 2 days.
Age of the patient?
28 years old. And the patient did not give any history of fever, cough, or any abdominal pain, dysuria, hematuria, or there was no history of any passing of turbid urine or frothy urine. The patient did not give any history of any passage of blood in vomiters or blood in stools. There was no history of any headache or any weakness of the limbs or seizure. And the patient also tells that she felt reduced movements since today. Along with that, the patient had fetal movements were reduced. Okay. So, and the USG Doppler was taken from outside, which showed fetal growth restriction. So they came for the further treatment for the same. Okay. And on asking the allergic history, the patient was allergic to iron sucrose. So along with that, we asked the medication history. So medication history, the patient was on Tylenol, 100 microgram morning dose, and the patient was on Visalon, 20 ml.
What is the heart rate?
The heart rate was 80. Yes. And the patient was on Visalon. 20 mg.
So what do you think this patient, Tylenol, is taking 100 microgram?
Yes.
Even when she is having anemia, so much of dehydration, heart rate is only 80. What do you think?
The patient is still in a hypothyroid state.
Still in hypothyroid state. Yes. Normally, when pregnancy, you need to have at least 25% extra dose requirement.
Yes.
So this patient may require more Tylenol.
Yes. And the patient was also taking hydroxychloroquine. And the patient now is currently on ecospirin, 75 mg OD dose, and also on patient was on low molecular weight heparin, 0.1.
Short aspirin, ecospirin during diarrhea.
Sorry.
Should we stop this aspirin during diarrhea? Is it required?
It can cause gastritis symptoms, but
can it cause diarrhea?
No.
It's an anti-diarrheal.
Anti-diarrheal.
So nothing to worry about diarrhea. So we can continue. Many doctors stop it.
Oh.
It's not required. There is, like you told, gastritis. You can cover the gastritis with something else and give.
Yes, sir.
Because you cannot stop the drug here. Because it's a must.
Yes. And the patient is also on low molecular weight heparin, 0.4 mg subcutaneous dose. Okay. And the past history, the patient is a known case of a secondary Aplar syndrome with a SLE overlap. So the patient was also a known case of hypothyroidism. and following which we
How
had.
do you monitor the fetal circulation here? What is important here?
We should look about the mainly the diastolic flow. The diastolic flow is the which we look in the fetal.
Heart rate.
The
Fetal
heart
heart rate. What will happen to the fetal heart rate?
fetal heart rate will also reduce.
So we have to be very careful. There is one condition where fetal heart rate can be reduced. Apla can produce
Yes.
low fetal heart rate.
So in this patient, initially itself, we had also gone to a systemic examination. The chest was air was bilaterally equal. There was no presence of any added sounds. Parotid was soft, and the period of gestation there was 27 weeks. But according to abdominal palpation, the period of gestation we were able to get only 16 weeks.
Okay.
So following which we had also given a gynecology consultation during that time. Okay. They had checked the fetal heart rate. It was found to be reduced. Yes, and
bradycardia, heart block, congenital heart blocks, all these things are very common in APLA.
yes, and following which we had also as initial part of management, we had after doing a screening echo, we did a screening echo and checking the IVC collapsibility. The IVC was also collapsible. We had given fluids initially at a maintenance dose of 100 ml per hour fluids because patient was the tongue was dry, so patient was dehydrated. So we had initially started with fluids, and we had given injection pantoprazole 40 mg IV stat was given along with MSH, and the patient was also given Ridotil, Resicatrol was given. Following which, then we had the patient had a counts of 17,000. So we suspected it to be an infective cause of gastroenteritis. So we had started around antibiotics of injection ceftriaxone, 1 gram IV stat dose was given. Following which we are also
procalcitonin level?
Procalcitonin was 1.1. So along with that, we had sent the labs. The labs, the TSH was 1.21, CRP 51.21, creat was normal 0.3 with the total bilirubin of 1.72. The SGOT was 64 and SGPT was 34.6.
She was taking steroids also.
Yes, or Visalons.
Why she was taking for this APL?
Yeah, for APL itself she was taking. She was on HCQ also for the same. And following which, then the gynec did the fetal monitoring, was found to have fetal growth restriction, and then we had given a heparin stat dose at the time itself. Low molecular weight heparin 0.4 mg subcutaneous dose was given, and then
is there a difference between low molecular weight heparin in APLA syndrome?
Ideally, low molecular weight heparin is preferred over unfractionated.
It's an OPD based treatment, continuously patient has taken, so that yes. Low molecular weight heparin has got a better this one over heparin in case of APLA
syndrome. And so following which we came to a diagnosis that the patient is having a antiphospholipid antibody syndrome causing fetal growth restriction. Okay. So that was what we came to the conclusion.
INR, what is the INR?
INR was 1.73 with a PTT of 40.
40. Yeah. PTT is
elevated. We are also given a rheumatology consult for this patient, and they are told to continue the same drugs, and the patient was kept for observation. And actually, moving on to the APLA syndrome. So the antiphospholipid anti syndrome is basically defined as a occurrence of thrombosis or pregnancy-related morbidity, along with autoantibodies against the phospholipid binding protein. So antiphospholipid antibody syndrome is usually divided into primary and secondary. So primary is usually due to idiopathic causes. Secondary mainly due to occurring conditions like SLE. So SLE can have antiphospholipid antibody, so further causing antiphospholipid syndrome.
And sepsis itself can produce APLA antibodies positive in many patients. Yes. That we should keep in mind.
Yes. And the diagnostic criteria initially was the Sapporo criteria. In 2006, that is one clinical and one lab criteria. So the clinical criteria is usually a confirmed thrombus, usually the arterial or venous or small vessel thrombus, and or a pregnancy morbidity. So,
what are the conditions you get arterial and venous thrombosis other than APLA syndrome? So there are conditions which produces venous thrombosis. There are conditions which produce arterial thrombosis. There are conditions which produces both. One is APL, the other one is
like proteinous deficiencies.
That all produces venous thrombosis. hyperhomocysteine. That produces both arterial and venous thrombosis. Okay, that is also very common, especially in smokers, male patients.
And usually there could be a pregnancy morbidity. So that is usually the recurrent fetal loss before 10 weeks. Or the patient would have a fetal death beyond 10 weeks also. And or premature birth from placental insufficiency. This patient already had 3 episodes of abortions previously. So this patient had undergone a cerclage also.
Okay.
Initially itself. And history of there will be a possibility of preeclampsia in these patients. So, and laboratory criteria is usually it is usually done in 2 or more occasions at least 12 weeks apart. The lab test must be repeated. That is usually the direct ELISA test. That is with medium or high titer IgG or IgM antibody against cardiolipin antibody. That is an anti-cardiolipin or beta-2 glycoprotein. So anti-beta-2 GP1. So that antibodies are which are usually involved, and also lupus anticoagulant can be involved. So lupus anticoagulant is usually an acquired hypercoagulable state. So what happens is which block the phospholipid surfaces, and that's why there will be increased coagulability. So which occurs, and APTT will be raised in such individuals. And
when APTT alone is elevated, in some patients you can see APTT alone is elevated. What are the reasons for that? PTN may not be elevated.
So,
what do you do then? APTT alone is elevated.
drug
Apparent. Then APLS syndrome.
APLS syndrome.
Mostly APTT alone will be elevated sometimes.
Yeah.
But then you have to do a mixing study. What is mixing study?
In mixing study, usually we should give a like normal platelet with FFP. We give it as correction, but still it won't be corrected.
Okay.
Because there is always a lupus antibodies present.
Okay.
So it acts as an anticoagulant.
Okay. So whenever you get a APTT isolated elevation, you have to ask for a mixing study.
Yes. And there is actually now a new ULAR criteria, 2023 guidelines. According to that, there
ULAR?
European League of Rheumatology. Yes.
Okay.
And in that, there is actually certain domains. So in domain 1, that's usually the macrovascular venous thromboembolisms.
Okay.
So which is involved the pulmonary embolism DVT features, or patient can have a spontaneous splenic thrombus or renal vein thrombus, or cerebral venous thrombus, and also retinal vein thrombus also can be involved. Domain 2 is mainly the macrovascular, the arterial thrombus. So arterial thrombus mainly involves it could be a myocardial infarction, so the arterial thrombus, along with the peripheral or splenic or arterial retinal artery thrombus also can occur. Domain 3 is usually the microvascular complications. So microvascular complications usually occur as skin manifestation. So that could be a patient of livedo or racemosa. So that's usually violaceous rashes which can be present in case of APLS syndrome. And they can also be present of livedoid vasculopathy also. Livedoid reticularis can also be present. And they can also present nephropathy. Nephropathy also is usually a microvascular complication. Pulmonary hemorrhage, myocardial infarction, and usually could be a non-ST elevation ME, and adrenal hemorrhage. So these are the microvascular manifestations. And domain 4 is the obstructive manifestations. That could be a pre-fetal death. So that's less than 10 weeks, or could be a fetal death if it's more than 10 weeks. And preeclampsia with severe features. So preeclampsia usually the systolic BP will be more than 140 and the diastolic BP of more than 90 in at least 2 occasions, about 4 hours apart. Along with the patient will be having proteinuria. And in these individuals, there will be also presence of increased BP. So that is a severe feature. Usually, if it's more than 140 in
how do you treat hypertension and pregnancy in that case?
Ideally, it should be treated with we can use labetalol. Labetalol is the drug of choice. So in these individuals, there will be systolic BP more than 160. So that is taken as the criteria, and diastolic BP more than 110. At least 2 occasions, 4 hours apart, and also severe headache, which is unresponsive to medications, and visual disturbances, pulmonary edema, and along with LFT derangement and renal function.
What is visual disturbance?
This is posterior reversible encephalopathy syndrome.
So that is a reversible encephalopathy. Most of the time patient will lose his vision.
Yes.
Mainly seen in hypertension. There are other reasons for losing vision in hypertension, but this is one of the reasons. Press. You have to search for press in this type of cases.
Yes, yes. Along with that, patient can have a thrombocytopenia. So usually the platelet count will be less than 1 lakh if it's severe features are there of preeclampsia. And placental insufficiency also. So usually there can be a presence of intrauterine fetal growth restriction. So in our case, the patient had an intrauterine fetal growth restriction.
But here it is not due to preeclampsia.
Yes.
BP is normal.
Normal. So
This
this
is a rather low.
no. So in this usually in APLA syndrome, the patient can have a
PLA itself can produce
fetal growth restriction.
In that again, that other part also can produce
Fetal growth restriction. Yes, and then the patient can have oligohydramnios also. Along with that, maternal vascular complications like placental thrombosis or infarction can also occur. And cardiac also there can be presence of valve thickening, mitral valve thickening, and also presence of valve vegetations like in SLE.
What is Miranda's endocarditis?
Is sterile. And
Same thing. What you are telling is that's the name of that. Sterile endocarditis seen in SLE.
SLE, yes. And there can be thrombocytopenia, already as mentioned before. So the treatment mainly involves in case of there is actually a thrombotic APS and also obstructive APS. So if this patient is only having a thrombotic episode, like a patient having venous thrombosis, arterial thrombosis, they should be given a prophylaxis with a low dose aspirin. So low dose aspirin, no dose of 81 mg tablets. So 81 mg per day can be given 1 or 2 tablets, and maximum if its patient is in preeclampsia, the dose must be more than 100 mg per day.
So most of the patients who have hypertension in pregnancy nowadays, they give aspirin prophylaxis.
Yes. Along with that, then we can give therapeutic dose low molecular weight heparin, which is usually an enoxaparin, 1 mg per kg every 12 hours, which can be given. And also oral coagulants or anticoagulants are contraindicated because they can cause fetal bleeding risk.
Why not it is HIT? This patient is having thrombocytopenia. Why don't you think about HIT?
Yeah.
What is HIT?
Heparin-induced thrombosis.
So how do you treat it? This patient, if you are suspecting, suppose if you suspect,
we just stop the drug.
So if you stop, the patient will have further complications.
We can replace with fondaparin.
You have to switch to fondaparin actually. Yeah. Then you can know whether it is due to heparin or the actual disease itself.
Yes. And
what is the DS-DNA level in this patient?
DS-DNA levels were found to be elevated. With the values.
So should we do DS-DNA is a prognostic marker of or diagnostic marker?
It is a diagnostic.
Prognostic means whenever disease is flared up, the values will go up. Diagnostic means whenever you diagnose, it will be high. And the treatment will not alter the values. Is it diagnostic or prognostic? This is prognostic. So whenever patient has got a flare up of disease, so most of these SLE patients, they present SLE flare up as an infectious disease. So you have to always check the DS-DNA values, and if it is very high, that shows that the disease itself flared up. It is not due to the infection. You can see SLE patients come with pneumonia. That pneumonia is actually most of the time it is not due to the bacterial infection. It is due to the flaring up of the illness. So always check the DS-DNA in this type of patients. If DS-DNA levels are very high, you have to treat that also.
Yes. And in case of obstructive antibody syndrome, usually we should give a prophylactic dose of low molecular weight heparin. That's usually enoxaparin 40 mg sub-Q in a daily dose. And we should, till postpartum also, we should continue the prophylactic dose of low molecular weight heparin and low dose aspirin for 6 weeks postpartum. And in cases of like if the patient is having an antiphospholipid antibody positive but there is no all the criteria of APLS syndrome is not meeting. In such individuals also we should start on low dose aspirin. So that is the initial line of treatment. Timing of delivery is usually.
Aspirin affect venous thrombosis?
Aspirin doesn't affect.
It affects only arterial
thrombosis. Yes.
So this condition affects both artery and venous. That's why we are giving one side aspirin, other side heparin or warfarin or newer anticoagulant drugs. Yes. So both should be given.
Yes. And the timing of delivery is usually between by 39 weeks. Before 39 weeks, delivery must occur. And there is also a feature of catastrophic
catastrophic SLE or catastrophic APL.
So in that there's usually a multi-organ dysfunction. There's more than 3 organ systems must be involved. Along with it must be acute in onset.
What happened to the rash now? You have to tell me what happened to
the rash. So in
rash, is it significant here?
This patient, according to the history, the patient had given a history that the patient was allergic to iron sucrose.
So iron was given.
Yeah, so following the iron sucrose injection, the patient had developed this kind of
Then
rash.
what happened to the rash?
Then
Rash persisted?
rash had persisted and then has formed as minor scars. Yes. So that's
if they disappear immediately, what will you suspect?
It could be due to the SLEs.
What is it?
Discovered rash.
What is it? In SLE patient, rheumatoid arthritis patient, whenever fever is there, rash occurs, ferritin levels are very high, what will you suspect? Adult onset Still's disease.
Still's disease.
There is a part of SLE, like you told, primary and secondary. Primary Still's disease can come, but as a part of SLE, rheumatoid arthritis, there also it can come. So whenever rash comes, you have to be very careful. Whether it disappears with the fever, then it is possibly indicating another problem, which is similar to immune-mediated disease. Okay. What happened to the patient finally? Steroids, what happened? Steroid dose, what did you do? She was taking 10 mg steroid every day. Diarrhea was there, hypertension was there. What will you do?
Yeah, to increase.
You have to immediately give hydrocortisone injection 50 milligram QID, then check the cortisol level. If cortisol level is adequate or normal, then you can switch to your older dose. A slightly higher dose can be given. Because whenever you are having stress, if you are on chronic steroid use, then there is a chance of steroid insufficiency. So you have to give slight extra dose.
About like 3 times.
You have to double the dose.
Double the dose. Yeah.
That has to be taken care of. Otherwise, patients' BP will be persistently, because their adrenals are not going to secrete steroids. Their system is not going to secrete steroids. It is completely suppressed by your external steroids. So we have to be very careful. Okay.